Dear friends, good evening to everyone. On the behalf of Endocrine Society of India Rajasthan affiliate, I feel honored to welcome you all, delegates and faculty members, for taking keen interest in this important academic event. I'm sure you all will feel enriched with knowledge after completion of this event. So again, I welcome you all in this our thyroid symposium. Now I'm handing over to our chairman, Dr. Prakash Keshwani sir, to say something regarding this event. As you all know, Dr. Prakash Keshwani sir doesn't require any kind of introduction. You all must be knowing him very well. But as he's a senior professor in Department of Medicine and he's the endocrinologist, he's teaching faculty for medicine and endocrinology. He's the president of Endocrine Society of India Rajasthan affiliate. He's member faculty selected board Institute of IMS BHU Varanasi. He's joint secretary of RSSDI Rajasthan chapter. He's scientific chairman of Jaipur API chapter. He has more than 30 publications in national and international journals. And he's the organizing secretary. He was the organizing secretary of the RSSDI 2019. That was the most successful RSSDI event in the history of RSSDI. So now I'm handing over to our chairman, Dr. Prakash Keswani sir.
Thank you, Sanjay, for your kind introduction. A very good evening to all. And luckily, this time we are going for our fourth symposium that is on the thyroid hormone diseases. And we have a very brilliant team of speakers with us. I hope the talk will be useful to all, and we have such kind of speakers that everybody will be get benefited from this. All the physicians, endocrinologists, and practitioners. These topics are related to the general physicians also, and luckily we have a very highly selected team of endocrinologists from India, and the first talk will be delivered by Madam Sarita Bajaj. She is one of the senior most endocrinologists of the country. She is a legend in the field of endocrinology, and we have a very long association and blessings by Madam Bajaj for a very long time. She had been president of RSSDI, and at that time, if we remember, we all endocrinologists went to the Lucknow in the scientific program made by her. She is the founder president, South Asia Federation of Endocrine Societies, SEFIs. She has been the president of Endocrine Society of India and editor-in-chief, ESI Manual of Endocrinology, first and second edition. She also established the RSSDI UP and is still the most pioneer worker in the RSSDI and has been awarded with the Lifetime Achievement Award by the Diabetes India as well as the UP Diabetes Association. She has delivered several prestigious orations and has established Diabetes Education Foundation in the Prayagraj since 2001. Her area of interest are endocrine education, thyroidology, and obesity. More than 200 publications are credited to her in various national and international journals. She is Director Professor and Head of the Medicine, MLN Medical College, Prayagraj. We are honored by her presence, and now I request Madam to please start her deliberation.
Thank you.
Thank
you. Visible, audible?
Yes.
Yes. Am I visible and audible?
Yes, madam.
Okay. So thank you, Prakash and Sanjay. Thank you so much for those very, very nice words and for the invitation. I'm deeply honored. So, and of course, thyroid, like I said, I'm very, very happy to be talking about thyroid. It's definitely away from diabetes. Diabetes is more commonly spoken, but thyroid is equally important. And I'll be focusing on subclinical hypothyroidism. There are a lot of questions there are to answer. Some of them I had listed in the first slide, but there are many more which need to be addressed. And I hope I'm able to address all of them appropriately. So we cannot move ahead without a definition. The important word here is persistent, which I will be coming to time and again throughout my talk. So if the TSH is elevated persistently, but associated with normal levels of whether it is total or free T3 and T4, and no clear symptoms of hypothyroidism, then we will say this is subclinical hypothyroidism. There are other names which are associated, but this is the name that has come to stay. Easy to remember, when we talk of subclinical, we mean a range of usually 4 to 10 in the majority, that is about 90% would fall into this range of TSH. And interestingly enough, it varies from 4% to 10%. In India, we have a total of about 42 million people with thyroid disorders, and the prevalence of subclinical hypothyroidism is 9.4%, much more common in women as compared to men. So the answer here is it's common, much more in women and in older people. So this, where do we get this data from? This data comes from here. You can see that less than 40 years, not only is the prevalence low, but it is almost equal in men and women. But over the age of 40, the prevalence in women increases and overall prevalence is also much higher. Is there any biological variation? When I said persistent in the beginning, why did I say that? Because the TSH may vary up to 50% between tests. And you know, our patients go crazy. Now, this is my report. I will have to confirm it from another lab. So, okay, you can get to 50% variation. And mind you, the daily fluctuations are up to 26%. So what happens? 62% of them would normalize without intervention in about 5 years. Half that in 2.5 years, it's about 40%. Okay? 2.5 years, 40%. At 5 years, about 62%. And the annual rate of progression to avert hypothyroidism depends on whether you have associated anti-TPO antibodies. So if you remember 1 to 4%, that is good enough. Both TSH anti-TPO more, TSH alone 2 to 4%, with anti-TPO antibodies it's 1 to 3. So I've already discussed the biological variation and the fact that it goes up with age. Why is it increasing? Because you have so many guidelines. Each guideline is saying its own thing, whether it's a US Preventive Service Task Force, they say it's insufficient. ATS says age is 35, another says more than 60, another says more than 50, another says women. So all these guidelines are differing. So what should you recommend? You should look for aggressive case finding and which are the patients who are more susceptible. So if there's a family history of thyroid disease, goiter, neck irradiation, partial thyroidectomy, dyslipidemia, atrial fibrillation, unexplained weight loss, hyperprolactinemia, any autoimmune disorder, and use of medications which affect thyroid function, then these are the patients we need to test. What is the net result? I told you, so many guidelines, so many age cutoff, yes, for women. So in this study, 57% of 55-year-old women were screened, but only less than 5% required treatment. So why are they being screened so frequently? Don't you remember patients coming up to you and say, oh, please, doctor, there's something wrong with my thyroid. I'm gaining so much weight. So patients request you for tests. This is what has been seen. And then physicians' practice patterns and beliefs are also variable, as I have shown you from the guidelines. So the bottom line here is individualize. Do these patients have symptoms? I mean, these are the symptoms I've listed, but what has been seen, symptoms are insensitive, non-specific. They would not rule out thyroid disease because 18% of euthyroid, 22 with subclinical and 26 with overt had more than or equal to 4 symptoms. So don't look at symptoms. The screening for TSH is how we are going to catch these patients. Can it be a transient rise? Yes, these are the conditions. I've shown you some physiological examples, recovery after non-thyroidal illness, after thyroiditis. If you are withdrawing chronic levothyroxine in a euthyroid individual, and what season are we in the north? This is winter time. So there it is known that there can be a seasonal increase in TSH as well. When I said persistent, because there are circumstances when it is elevated, but it is not true subclinical, elderly, marked obesity, and then there are some rare causes as well. For example, now look at this girl. She's obese, she's gaining weight since the age of 4 months, and she comes to us with a raised TSH, which is between 4 to 10. So, will we do anything about it? This is the question that I'm addressing here. So, why are we looking for subclinical hypothyroidism? Because there are a host of complications associated risk factor of atherosclerosis, cardiac function, dyslipidemia, some element of depression. And I'm not going to be talking about pregnancy because we have Dr. Manoj Chadda who will be addressing this whole issue of thyroid and pregnancy. So this is my disclaimer, no discussion in the context of pregnancy. What happens? Do we have data which tells us that you can have elevated lipids? Definitely, a small group of patients with abnormal TSH, you can see that in the control as compared to the subclinical hypo, there was a raised cholesterol as well as LDL, which was significant. And what happens with treatment? That is also important. Does it improve? Yes, levothyroxine replacement reduces the cholesterol, both cholesterol and LDL as well. So there is the proof with the treatment modality as well. So again, cardiovascular system, there are a host of manifestations from increased left ventricular systolic diastolic dysfunction, arterial stiffness, carotid intima media thickness, diastolic hypertension, cardiac autonomic dysfunction as well. Do we have data for intima media thickness? Absolutely. So this is the mean intima media thickness in patients with subclinical hypo as compared to those who are controls, and the maximum IMT is also increased. So this is, we know, is a very important early marker of atherosclerosis. What about the cardiovascular outcomes? Yes, in the Rotterdam study, it was shown that it is a strong indicator of risk for atherosclerosis and myocardial infarction in elderly women. Now, I am saying elderly. I'll come to the cutoffs for elderly later. And levothyroxine treatment, what happens if we look at the end points? No levothyroxine versus levothyroxine as far as the coronary events are concerned. Yes, a significant difference in individuals less than 70, but not when they are more than 70. And again, we are talking of subclinical hypothyroidism here. So there's a host of complications associated as far as the cardiovascular disease is concerned, both subclinical and overt hypothyroidism. So why are we going to treat? Have I answered that question? Yes, the answer is because of the altered cardiac function, lipid abnormality, and cardiovascular outcomes. The second is progression to overt hypothyroidism. What are the predictors? How do we know it is going to progress? So the TSH level, as you can see here, if it was 4 to 6, there was hardly any progression. 6 to 12, almost 43%. More than 12, it was about 77% progression. So in this study, in women who were elderly with a higher TSH and anti-TPO antibody positivity determined the progression. So these are the predictors of progression, and I only need to add goiter to that. This is where we are. So your euthyroid here, this is subclinical and overt. So the progression is about 1 to 5%, which I had shown you earlier, and it definitely depends on your antibody status. I've already said that 60% would reverse to normal in about 5 years if you follow them up. Even renal function abnormalities have been seen. The eGFR is decreased, and patients requiring hemodialysis have a higher mortality than those who are euthyroid. Now, this is our own data. So we separated them into 2 categories. So these are patients with subclinical and overt hypothyroid. That is obviously more of subclinical as compared to overt. As the diabetic kidney disease, I'm talking of diabetic kidney disease here. As the stage of kidney disease advanced, the prevalence of hypothyroidism increased. And what we did is we replaced levothyroxine in patients with subclinical, followed them for 3 months and 6 months, and there was a significant improvement in eGFR. So the eGFR significantly improved in patients with diabetic kidney disease who had associated subclinical hypothyroidism. Similarly, patients who did not have diabetic kidney disease, they had the similar findings. The prevalence was hypothyroidism was greater as the renal function declined, and treatment reviewed after 3 and 6 months showed a significant improvement in eGFR. So this is one very important indication to treat. Yes, there is association with neurobehavioral abnormalities, depression, anxiety, somatic complaints like fatigue, altered mood, and cognitive abnormalities. Even thyroid cancer patients, there is a higher TSH associated with incidence of advanced differentiated thyroid cancer and those with more of lymph node metastases. What about childhood? What do we do with these children? This is a retrospective study, 2 to 18 years. They found it to be common, benign, remitting. The best option is to wait and watch and individualize. What do I mean by individualize? Again, if it's a female child, higher baseline TSH, TPO positivity, yes, it is likely to progress. What is the approach? Okay, so we've asked for symptoms. We've done a thyroid and a lipid profile. We've looked at the antibodies. If there is a goiter, it would be a good idea to look at the ultrasound for gland size and findings of autoimmune thyroiditis. And you would need to do a cardiac evaluation in a certain subset of patients. So what are we going to do as far as the management is concerned? So when I'm talking of underlying thyroid disease, I'm talking of previous thyroid surgery or raised autoantibodies. In an adult, if the TSH is more than or equal to 10, on 2 separate occasions, 3 months apart, we will start treatment. If the age is less than 65, then we would give a 6-month trial. If the TSH is less than 4, between 4 to 10, again, 2 separate occasions, 3 months apart, and symptoms are present. So now we are monitoring those symptoms. If the symptoms do not improve, we will re-measure TSH. If it is still high, we will adjust the dose. If the symptoms persist, TSH is normal, we will stop levothyroxine. In children, we will very clearly start if it is 20 or more, between 10 to 20, 2 separate occasions, 3 months apart. Yes, we will start if it is again maintained high at this time. If it is 5 to 10, we have repeated it. We will start if there are signs or symptoms or thyroid dysgenesis. How to replace? Less than 65, we will start off with 25 to 75. I'm talking of subclinical here. Over 65, it is 12.5 to 25. Monitor at 1.5 months to 2 month intervals. This is the target that you want to achieve. Continue monitoring every 6 months to a year. The goal is the symptomatic improvement or a normal TSH. Remember, up to 40% may have features which are suggestive of hyper, that is a low TSH, that is over replacement, and they will require more frequent monitoring for a longer period. What are the risks of overtreatment? Obviously, there's features of hyperthyroidism. If the bone mineral density decreases, you can get osteoporosis, you can get fractures, you can get atrial fibrillation as well. So what are the risks of overtreatment, or what are the disadvantages? The regular visits, the blood samples, the daily medication, which may be lifelong, and the over 65, the benefits are the lowest. And these are the individuals who are most susceptible to the dangers of overtreatment. So here, treatment should be individualized and implemented very cautiously. In the olders, this is a very important study from the Trust study group. In this age group, mean age group was about 75 years, and they showed that there was no apparent benefit in older persons with subclinical hypothyroidism, whether it was in the symptom score or in the secondary outcome measures. Okay, so what happens? You started the treatment, or you have decided not to treat. How are you going to follow up? So if you have decided not to treat, or you have stopped the treatment, you will follow up once a year. If there are very strong clinical features, every 2 to 3 years if no features are present. In children, you will monitor 3 to 6 months if there are strong features, 6 months to annually if there are no clinical features. Again, I go back to the elderly. I've already said above 65, but even over 85, no benefit for any outcome whatsoever. So, what is the goal TSH? As age advances, the TSH goal also goes up, and at the age of 85 above, we actually do not know what goal to target. Right, so this is again in a way a summary. No evidence to support adverse for metabolic syndrome, obesity or diabetes. Dyslipidemia, yes, treat. Cardiovascular endothelial dysfunction, yes, if the age is less than 65. Chances of stroke, yes, if the age is less than 65. For psychiatric and cognitive dysfunction, it's a plus minus. You have to give a trial. For neuromuscular dysfunction, exercise intolerance, no. Bone health, again, too few clinical studies to define a role. So what do we have here? So this patient, she's 49, she's recently been diagnosed, she's gained 8 kilos, she has a very high BMI, she's well controlled on 50. And she's saying, my weight. So do you think the weight is because of the subclinical at the moment? The answer is a clear-cut no. But these patients, they love to talk about their thyroid problems. And this is what the doctor tells them, that then there will be nothing for you to talk about if I don't convince you. So there are tears and anger when you tell them that it's not their thyroid that's causing their problem. I would like to conclude by saying that it is a common disease. Anti-TPO antibodies are very important to decide risk of progression. It may be associated with heart disease. Middle age, we have to look at the neurocognitive impairment. Overdosage, be very careful in elderly individuals. No benefit over 65, and you can observe them without treatment. Yes, you would treat over 10, especially young and middle age with symptoms consistent with mild hypothyroidism. And sometimes you definitely need to look at life from a different perspective. Thank you. Thank you very much.
You have made so many things clear. Who has to be investigated, and what treatment has to be given. Am I audible?
Yes, you are.
Yes. And this was and it must have cleared many of the doubts from our endocrinologists and physician friends. Thank you, madam, very much. We will go for the question answer in the last of the 3 talks. Now we go for our next speaker. Luckily, So our next speaker is Dr.
Ashu Rastogi.
Ashu Rastogi. He's a very brilliant, talented speaker from PGI Chandigarh. When we were talking with the Dr. Bansali for some good speaker, he suggested that Ashu Rastogi has a good work in the field of juvenile hypothyroidism, and there can be no better one to talk about the juvenile hypothyroidism. Dr. Ashu Rastogi is faculty in the Department of Endocrinology, and more than it, he is from Jaipur only. That is the most important for us. He has more than 60 publications in various national and international journals. He is recipient of Fellow of American College of Endocrinology, FRCP, Young Investigator Award by American Association of Clinical Endocrinologists. He has Best Research Paper by US Endocrine Society, Best Research Paper by the IWFJ, and so many papers. And she has also received Professor B.R. Srivastava Oration in the RSSDI 2017, A.R. Sheth Award by the Endocrine Society, A.V. Gandhi Award by the Endocrine Society of India. He has also received Outstanding Paper Award by US Endocrine Society by San Diego, USA. He is Vice President of Diabetes Food Society of the India, and he is Treasurer of RSSDI Punjab chapter. Above all, he is a very brilliant endocrinologist and very good orator also. Now to Dr. Ashu Rastogi, please start with your.
At the outset, definitely, I will like to. I hope I am audible.
Yes, you are audible.
Yeah. So thank you, Keshwani sir. He has been my teacher during my SMS days when I was doing my graduation in SMS, and I really thank him for giving me another opportunity to speak on a very interesting topic. And it's a topic that is very close to my heart again, because sometimes if you make a proper diagnosis at this point, definitely it can change the treatment and the life of a patient. So, and I'm also thankful to Sanjay that again he has given me an opportunity, because it was a very close watch, because just within 48 hours I have to prepare this presentation. But whatever, I'll be talking on juvenile hypothyroidism, and I'll be mainly dealing with the clinical cases that we have seen and what they have taught us during our journey in the PGI. First of all, I'll just present a simple case that was an 18-year-old female who presented with acute abdomen in a surgical emergency 3 years back. Immediately she was, yeah,
slideshow kar dijiye screen.
I'll do that. Immediately she went into the OT and she underwent an oophorectomy. She remained undiagnosed, untreated. Surgeon was happy. That was ovarian torsion. So oophorectomy was done, but unfortunately nobody realized that what is the primary diagnosis. After some time, she again presented to emergency department with headache and vision loss for a period of 1 year. Somebody did an MRI and it was found to have a cellular and supracellular mass, and then she was referred to a neurosurgeon. So on examination, we just got a call from the neurosurgeon and we found out that something is wrong, and we found that she was having severe short stature. She was having dry skin and delayed deep tendon reflexes, though there was no goiter, but she again had a palpable mass up to umbilicus. His light perception was present, but still her vision was severely impaired. Moreover, her T3 was very low, her T4 was very low, and TSH was sky high. It was more than 1,000 micro units per liter with anti-TPO, which was positive. And you will note that the cortisol was also low. It was only 90 nanomoles per liter. She had a FSH of 17.8 with the LH of 3.6, which was low for an 18-year-old woman. And you can see the prolactin was sky high again of 154.9. Now, this was the MRI that was obtained from this girl. You can see such a huge mass which was extending from the sella into the supracellular region and even encroaching the third ventricle. And the optic chiasm is also engulfed in the mass. That's why she was having vision impairment and vision problem. Moreover, the mass was also reaching up till the cavernous sinus. Anybody would imagine that this was a pituitary tumor and this would be immediately sent for neurosurgery. But we again got an ultrasound abdomen and we were surprised to see that she was having such a huge mass in the abdomen, and this was an ovarian cyst. You can see this multiloculated cyst, and this was an ovarian cystic mass, multicystic mass. I hope that my respected audience would be able to recognize that what we are dealing with and what is the case behind. This is the case of simple primary hypothyroidism, which was unfortunately missed because this lady or this girl had juvenile hypothyroidism. She was TP positive. She might be having hypothyroidism around 9 to 10 years of age. Therefore, because of the decreased clearance of FSH and also the specificity spillover, the TSH, which is sky high acting on the FSH receptors, which leads to the formation of this follicular cyst that was responsible for this ovarian mass, which undergoes torsion and acute abdomen, which was finally, unfortunately, operated by a surgeon. But we prevented a pituitary surgery because this lady was then managed by a simple, she was hypocortisolic, so she was managed on hydrocortisone of 5 milligram TID and levothyroxine of 50 microgram, and gradually the dose was built up to 125 microgram weekly. So you can see this mass started to decrease because this was mainly the thyroid of hyperplasia. This was not a pituitary adenoma. This was not a prolactinoma. This was just a stock hyperprolactinemia and a thyroid of hyperplasia. Just by giving levothyroxine, the mass gradually resolved. The ovarian mass that was also present was resolved. The patient also resumed menses. And that is the beauty of identifying a proper diagnosis in a girl who presented with an acute abdomen and headache and with visual loss. You can see there was a significant regression of the mass after the treatment. Now, coming on to the second case, it's again a case that we published in the BMJ case reports as precocious puberty and a cellular mass. Now, how would you would imagine that how would a girl who probably because I'm giving a lecture on hypothyroidism, how would she present with precocious puberty? So let's see. So she was a girl of 2.5-year-old. She had a progressive breast enlargement, which was for 3 months. And The most worrisome aspect that brought the child to the hospital was that mother was worried that my daughter has having a vaginal bleed, and it was a single bleed that brought the child to the hospital. We evaluated the child. She was less than third centile. You can see it was only 80 centimeters, and you know that the height is significantly less. The projected adult height was also less. Her heart rate was low for a child. This was only 70 per minute, though it was regular. But most glaring finding was an sexual maturity rating. It was B3. So it was a precocious puberty, because you don't expect a B3 at an age of 2.5 years. She was not having any kind of goiter, and her tender reflexes were normal. We evaluated further. We found out that her bone age was only 2 years. LH was undetectable. That means it was not a gonadotrophin dependent precocity, though FSH might be elevated, especially if you are dealing with a case of hypothyroidism. Even if the patient is not having puberty, you can have an FSH of 10.2, and prolactin was again high. Interestingly, her TC was very low. Her T4 was almost undetectable of 1.4 microgram per deciliter. Her TSH was 193 and TPO was again positive. Ultrasound ovaries again showed us multiple small cysts and a cellular mass. You can see that's a 2.5-year-old girl who presented with a breast enlargement of B3 along with a cellular mass. You can see a subcellular along with a supracellular extension, typically a figure of 8 kind of mass, which is present in the pituitary region, which is not extending beyond the cavernous sinus. And you can see the optic chiasma. So this mass is pushing the optic chiasma. So this is an interesting scenarios you can have in a very simple disease that is called hypothyroidism. Once we got an bone X-ray, you can see hardly 2 couple bones are visible, and both the radius and ulnar ends are very premature as compared to a child who is around 4.5 to 5 years of age. So her bone age was only 2 years. We made a diagnosis of childhood hypothyroidism because TPO was positive. We made a diagnosis of Hashimoto's hypothyroiditis. In addition, it was gonadotrophin independent precocious puberty because LH was undetectable, and as patient was having a cellular and supracellular mass, which is suggestive of thyrolactotroph cell hyperplasia. We just managed the case with levothyroxine 25 microgram, and those were hiked subsequently to 75 microgram. And you can see by that, the TSH started to decrease. The specificity spillover was no more there. The FSH clearance, which is remarkably decreased in patients with hypothyroidism, started to clear. So FSH was again decreased, and she has significant resolution of breast without any GnRH analogs. So remember, in a patient of hypothyroidism, it's very important, or a girl who presented just by 2.5 years of age with precocity of breast enlargement of B3 and Minaki or a single menstrual bleed, it's very unlikely to be gonadotrophin dependent precocity, because remember, gonadotrophin dependent precocity usually progresses through stages of SMR stage 2, 3, 4, and 5. That is the usual course. But it is very unusual to have a vaginal bleed at a breast stage of 3. That suggests there is some ovarian follicular cyst which is responsible for causing this vaginal bleed or a withdrawal bleed, because these ovarian follicular cysts secrete estrogen, which is intermittent. So there would be intermittent rise of estrogen, then sudden withdrawal and a vaginal bleed, that is a withdrawal bleed. Also, the patient did not require any kind of the pituitary surgery. After levothyroxine, the pituitary enlargement significantly decreased. You can beautifully see the normal pituitary, the cella, this is the stalk which is in the midline, and the optic chiasma. So everything was normal. So hypothyroidism in children, remember, it can be either congenital, where we know that, which is the primary hypothyroidism is most likely, that is because of either thyroid dysgenesis or thyroid agenesis or thyroid disharmogenesis. Agenesis, we know that it will not show any kind of uptake on technetium scan, and moreover, if you will do a USG thyroid, you will not find a thyroid on the ultrasound. But in thyroid dysgenesis, you might see ultrasound which will show a thyroid gland, but it will not show any uptake on technetium. But in thyroid dyshomogenesis, you might see a thyroid gland on technetium uptake because of TSH increase, and the thyroid ultrasound would also be normal, but the patient would have hypothyroidism. Otherwise, in children, thyroid causes are much more common, which can be either primary or it can be secondary. Primary causes are again much more common, that is juvenile hypothyroidism, which is usually TP positive, and Hashimoto's is the most common region of acquired hypothyroidism in children. And secondary hypothyroidism you can also see. So childhood hypothyroidism is usually labeled between age group of 5 to 15 years. You have to monitor the linear growth. You have to monitor any signs of pubertal delay, or even precocious puberty is also important. And cognitive function and mental development is usually normal in these children, and that is very important. Unlike congenital hypothyroidism, where the linear growth is markedly compromised, and moreover, these children would have impaired IQ and because of impaired neural tissue growth and differentiation. This is again one of the cases you can very well see just from the face. If this child enters into a clinic, you can very well make a diagnosis of hypothyroidism because the child is having a very puffy look, a prominent nose, a puffy these lips, and a very dull look and very dry kind of skin. She is also short, quite short as compared to her peers. So you can have a very usual presentations of hypothyroidism in the juvenile age, especially between 5 to 15 years, because the child might present with a short stature. Child might present with delayed puberty, might also present with precocious puberty, as I showed in one of the presentations in one of my cases. Child might present with diffuse goiter. Child might present with poor scholastic performances. And if it is associated with some thyroid of hyperplasia, they might present with hormone deficiencies, and that you should recognize before jumping onto a pituitary surgery. Sometimes they might have a monosymptomatic presentation just with goiter. Even peripubertal menorrhagia can be one of the presentation of juvenile hypothyroidism. Macroorchidism, yes. I talked mainly about the female cases who presented with the breast development and vaginal bleed. But remember, a male child can also present with macroorchidism. Again, that is because of increased FSH because of decreased clearance, and also TSH acting on the FSH receptors, and also because of deposition of GAG, that is glycosaminoglycans, in the testes. They can present with acute pain abdomen with a torsion ovary in the emergency department. So you might have to train your internist that acute abdomen in a child. Just remember, if it is ultrasound is showing some kind of ovarian mass, remember it can be a hypothyroidism. That is very important. They might present with primary amenorrhea or poor scholastic performance or refractory anemia. But yes, unusual presentation might be there, like precocious puberty, and you know that in precocious puberty you'll have advanced bone age. But if any chance you find decrease in bone age or delayed bone age, decrease in growth velocity, immediately you should think of precocious puberty because of hypothyroidism. If a child just present with limping gait, remember, if it is not related to trauma, it can be a dysgenesis of epiphyseal plate, that is because of hypothyroidism. Moreover, epiphyseal dysgenesis is very common, and after starting treatment with levothyroxine, these children can also have they might present with acute abdomen like torsion of multicystic ovaries, acute cholecystitis. And we have seen case of calf muscle hypertrophy that is also called a Kocher-Debris-Hamlin syndrome. I'll show you one of the presentation which was noticed by the father. He was very educated. He was a BSF person who noticed that his child is having calf muscle which was unusually large. So that can also be one of the presentation of hypothyroidism. They can present with headache and vision loss, as I showed in one of the case scenario. And sometimes they can present with dysphagia because of ectopic thyroid, like in lingual thyroid. This is one of the girl. Again, you can very well notice that she has a very a shallow look, dull look, and she has a very drying skin with a very bulbous nose and lips. You can also see where the very dull look. So she was again a case of hypothyroidism, and you can see epiphyseal dysgenesis. You can see the dysgenetic epiphysis and that she presented with limping of gait. This is one of the presentations. Now, was one of the boy who presented with both macroorchidism, though he was only around 6 years of age, but he presented with macroorchidism. You can see very large testes, and just look at the face of the child, which was sallow, dull, dry, puffy, typical look of hypothyroidism, but he was having marked calf hypertrophy, that is kosher debris syndrome, and it was the right calf muscle was much larger as compared to the left calf muscle. So, primary hypothyroidism can have an etiology like Hashimoto's thyroiditis, which is most common. Can be because of dysharmonigenesis, so you need to do a ultrasound thyroid or a neck along with a technetium uptake. You can have an ectopic thyroid again, which requires ultrasound and a technetium uptake. Iodine deficiency, yes, in some regions like in Himalayas, in Himachal, because I work in PGI, and we see many cases who come from Himalayas. They have iodine deficiency. Irradiation of thyroid can also lead to primary hypothyroidism or post-thyroidectomy. Central hypothyroidism, yes, that can also be one of the cause. It is because mainly of the pituitary transcriptor factor defects, the TPID deficiencies, some kind of tumors which is uncommon in the childhood age, and growth hormone deficiency on treatment with growth hormone. Remember, growth hormone can also be associated with a hypothyroidism, or it can unmask hypothyroidism because of the increased activity of deiodinase. And the macroorchidism and congenital hypothyroidism can also be seen in IGS-1 deficiency. So you need to differentiate between primary and secondary hypothyroidism, because primary hypothyroidism is very, very common. Usually mixed image presentation would be seen in primary hypothyroidism, but not seen in secondary hypothyroidism, because some amount of thyroid gland function is independent of TSH. So even if TSH is low in secondary hypothyroidism, still it will be sufficient for some amount of thyroid hormone to release and prevent any mixed edematous presentation. Goiter, you know that it may be present in primary hypothyroidism, but it will be absent because TSH is low. Concurrent hormone deficiencies would always and most likely would be present in patient with secondary hypothyroidism. T4 is reduced in both of these, though it is markedly reduced in primary. TSH is markedly elevated in primary, and it is always low and normal in secondary. TPO antibodies are more common in primary hypothyroidism, and if you do an MRI cella, it might reveal a cellular and supracellular mass or an empty cella if the patient is having hypoplastic pituitary. Peripheral hypothyroidism, we know that it can be rarely because of some other causes like thyroid hormone resistance syndrome, mutation in MCT8, and mutation in the serine iodinase enzymes, or consumptive hypothyroidism. So last, sometimes you might see a case of childhood hypothyroidism, which might be related with some kind of syndromes like Turner syndrome. They have much more tendency, especially if it is isochromosome associated Turners, which can have juvenile Hashimoto's hypothyroiditis or Noonan syndrome. Down syndrome, almost 1/3 of these patients have hypothyroidism. Type 1 diabetes, we know that 1/3 are TPO antibody positive, and around 10 to 15% may have subclinical to overt hypothyroidism. And if the patient is having celiac disease, they can also have childhood hypothyroidism. How to investigate? If you are suspecting hypothyroidism, always do serum T4 and TSH. You can do a TPO antibody. If your patient is having goiter, you might do an FNAC, though it is not required in most of the circumstances. If no goiter, technetium scan is most important, because then you might be dealing with thyroid dysgenesis or agenesis. X-ray is very important in childhood age, because either patient present with limp, and it can be epiphyseal dysgenesis, and it is also required for bone age. And remember, if the patient is having some kind of headache or visual symptoms, remember it can be thyroid hyperplasia. You need to do other pituitary hormone profile like cortisol, LH, FSH, testosterone, and prolactin, and an MRI cella. Primary hypothyroidism with stellar mass, it is because of thyroid hyperplasia. T3 and T4 would be low, TSH might be increased, and because of thyroid lactotroph hyperplasia. If it is secondary hypothyroidism, headache and vision defects might be there, cellular supracellular mass and pituitary stalk abnormalities on MRI might be there, and T3, T4, TSH all would be low in secondary hypothyroidism. Now, how do you treat? Last slide, Dr. Charita Bajaj has beautifully shown you how to treat this hypothyroidism, but I will be telling how to treat in children and in the juvenile age. If the child is 3 to 5 years of age, we usually give a dose of 6 microgram per kg. If child is 5 to 10, we give a dose of 4 microgram per kg. And more than 10, we start with 2 microgram per kg. We usually start with a low dose of 25 micrograms and we gradually increase the dose. Because remember, if you rapidly increase the dose, it has two disadvantages. One, or I would say a side effect, or it is a common complaint of parents that child has attention deficit disorders, because there is significant change from a low BMR to very high BMR, and the child start to behave abnormally because of attention deficit. So you need to build very slowly. Second, if you build very rapidly, it can also lead to slip capital femoral epiphysis. So remember, in a child, always start with a low dose and build gradually. For secondary hypothyroidism, you might need to initiate glucocorticoids before levothyroxine replacement and finally levothyroxine replacement. So you need to monitor the growth, because there might be catch-up growth in a patient with juvenile hypothyroid who is short stature. You might also be tedious in doing the SMR rating, because the child who presented with precocious puberty, you need to know the regression of the SSCs or the secondary cerebral characteristics. New onset of symptoms, headache, because pseudotumor cerebri has also been noticed with the levothyroxine doses. Attention deficit hyperactive disorder, I have already told you. Seizures and bone age need to be monitored, because it has been seen after levothyroxine replacement, there the bone age advancement would be significantly more as compared to the chronological age. So the bone age by chronological age might be more than 1. So you need to build the dose very gradually in pediatric age. And T3, T4, TS is definitely for monitoring of treatment. Remember, childhood hypothyroidism should not be missed. It has repercussions for whole of the life. Though it is quite frequently missed, we have seen, it is not an uncommon disorder. It requires a low threshold to suspect. Monosymptomatic presentation just with breast enlargement, just with acute abdomen are very common, and that should not be missed. And matter of hyperplasia presenting a pituitary mass is uncommon, but surgery should not be done, otherwise it will lead to pan-hyperpituitarism in a small child who will require a lifelong hormone replacement. So you should be judicious whenever you see a patient of a primary hypothyroidism with headache. It can be simple thyroid hyperplasia, and treatment and regular follow-up is always rewarding in juvenile hypothyroidism. So thank you, and Dr. Prakash Keswani, sir.
Thank you, Dr. Ashu, for a wonderful presentation and a very good collection of the cases. Really eye-opening cases, how pituitary tumor and precocious puberty or growth retardation occurs with the hypothyroidism. Not only physicians, but we endocrinologists must have also enjoyed these cases. Thank you,
Thanks.
Dr. Ashu, for your nice presentation. And after the third talk, we will be going for the question and answers. Thank you very much. And now we will be moving for the third talk of today's session, that is pregnancy and thyroid disorders. Pregnancy, of course, as Madam Sarita Bajaj told, that females are more vulnerable for the thyroid disorders, and pregnancy is an important period of time when not only the health of the mother, but the development of the fetus is also important. And for that, we have a very brilliant speaker for talking on thyroid and pregnancy. Dr. Badaram, can you put the introduction slide? He is Dr. Manoj Chadda. He is a senior endocrinologist from Mumbai. He is consultant endocrinologist at PD Hinduja Hospital and Hope and Care Center, Navi Mumbai. He is a teaching experience for DNB endocrinology since 2008 and has been ex-faculty in the endocrine department of KEM Hospital, Mumbai, and BYL Nair Hospital, Mumbai. He was trained in use of artificial pancreas biostator at University Germany. He has been the past president of Endocrine Society of India, past president of ISBMR, and he is member of Asia Pacific Regional Committee of IOF. He's a thorough gentleman, and brilliant speaker in the field of endocrinology. I request Dr. Manoj Chadda to please start his talk on the thyroid and pregnancy.
Okay, thank you, Dr. Keshwani and the team from Rajasthan for inviting me for this talk. Uh, in all fairness, thyroid in pregnancy is really a full day program and not a 20-minute talk. But I'm going to try to do justice to this by share. Okay, so that's the topic, and I'll try to cover up at least a few things which are of real relevance to physicians and in our practice also. We'll start with a case for pointing out one or two things important with the normal thyroid physiology in pregnancy. We look at a couple of cases in hyperthyroidism and hypothyroidism in pregnancy. I have put postpartum thyroiditis, but probably I'll not be able to discuss this in today's presentation. So let's start with a 24-year-old female who's 10 weeks amenorrheic. She complains of palpitations, tremulousness, poor appetite. Palpitations, tremulousness, already your mind is working towards thyrotoxicosis. But when I say poor appetite, then you have to think of other reasons. She's got a diffuse grade 1 goiter. Her T3 is 219, T4 is 15.2, TSH is 0.8. And there is a family history of thyroid disorder. So unfortunately, in these webinars, there is no time to question the audience and wait for the answer. So we are looking at a high T3, a high T4, but a normal TSH. So this should be the first indicator, because in any thyroid dysfunction, you would expect the TSH to change first. So this graph must have been shown to you time and again, and this is the physiology of thyroid in pregnancy, that as the pregnancy advances to the first trimester, the HCG levels go up. And HCG and TSH share the alpha unit. So there is some sort of specificity spillover and the TSH starts going down. So in a normal pregnancy, the TSH level starts going down and remains so till such time that towards the end of the second trimester, where the HCG starts going down, and that's the time when TSH becomes like a normal lady. So the important thing is that in the first trimester, it goes down. And till date, we are arguing on what is the normal level of TSH in first trimester. We'll discuss that in a short while. So the important part is that when you see a low TSH also in a pregnancy, it doesn't necessarily mean hyperthyroidism. As a matter of fact, you heard about subclinical hypothyroidism. Subclinical hyperthyroidism is seen often in pregnancy, but is really not associated with adverse pregnancy outcomes. So it generally does not require treatment. You can keep this patient under observation. And if she's putting on her normal weight, she's otherwise the baby is growing normally, you don't need to worry at all. We have been taught that with pregnancy, estrogen levels go up, so the TVG levels go up, so the total T4 levels tend to go high. And that's where the confusion comes up. So the tendency was to do free T4 till about a couple of years ago. Now, most associations have moved again back to T4 because the T4, free T4 that is done in the research laboratories are either by equilibrium dialysis, ultrafiltration, or the liquid chromatography mass spectroscopy. These are very expensive. They're not affordable. They are not available in our regular laboratories. So we should still go back and rely on the total T4. And I'll show you what changes to make. Keep in mind that whatever free T4 ranges that you're seeing in pregnancy are actually from the non-pregnant patients. There is no normal ranges of free T4 given in pregnancy. All in all, if you really look at the 2017 guidelines from American Thyroid Association, up to week 7, use the pre-pregnancy range of T4. Beyond week 16, increase the range by 50%. Between 7 and 16, where there's a little confusion, you increase the upper range of T4 by 5% every week. So 8th week is 5%, 9th week is 10%, 11th week is 15%. So that way, till you reach 16 weeks, and then it's just 50% more. So if your normal lab is, say, 4 to 12, then by the time of 16, it becomes 50% more, that becomes 18. So just keep that in mind. A 27-year-old female, again pregnant in the first trimester, palpitation, tremulousness, excessive morning sickness. No goiter, T3 249, T4 15, TSH 0.05. Definitely, you've got a thyrotoxicosis here. But it's very important to examine this patient in the presence of excessive morning sickness. These patients don't look as sick as a patient with Graves' disease. And you have to remember that much more than Graves' disease in pregnancy, it is gestational thyrotoxicosis which may be presenting in this manner with T3, T4 elevated or FT3, FT4 elevated, but with a suppressed TSH. It is associated with excessive vomiting. It is HCG dependent. Very often you just console the patient, give them symptomatic treatment, call them back after 4 weeks, and the patient is feeling much better. Vomiting has gone down. T3, T4 levels have started coming towards the normal for pregnancy, and the TSH starts going up. So don't rush into treat thyrotoxicosis in pregnancy, because most often they become, they're self-limiting. It's very rare that throughout pregnancy, the vomiting may persist and these patients may remain gestational toxic through the pregnancy. We look at this 10 weeks amenorrhea, 24-year-old female again. It's like the first case that I showed you. I'm repeating the same investigation. But suppose you were to see these sort of reports. The T3 has gone very high, 319. T4 is more than the 50% limit that I was talking of. And very important is now that the TSH has gone very low. So I repeat, when you're looking at thyroid function test, pregnancy or non-pregnancy, always start with the TSH and then look at the T3 and T4. So in this situation where you have diagnosed hyperthyroidism in pregnancy, anti-TPO may be positive, TRAB may be positive, depends upon where you are practicing and what are the investigations that are available. You have to use anti-thyroid drugs. You cannot think of using radioactive iodine during pregnancy. And surgery is an option only in the second trimester if the patient is not well controlled with anti-thyroid drugs or has a very large goiter. All in all, I think 99% of our thyrotoxic patients, our Graves' disease, would respond to medical treatment. In the first trimester, the choice of therapy is propylthiouracil. After second trimester, I remember as students, we were taught that propylthiouracil is the best drug to use in pregnancy. But because of the liver toxicity and the reports of teratogenicity with propylthiouracil also, there is no great advantage of using it beyond first trimester. After that, you use methimazole or carbimazole. Use it in the minimum dose required to keep T4 at the upper limit of normal. The TSH will come up gradually, but don't bother, but it's a T4 which should be kept at the upper limit of normal. Don't try to bring the T4 into middle range, because then this patient would actually be hypothyroxinemic. So when we have mild hyperthyroidism in a patient who is treated in the first trimester and the second trimester, in pregnancy, most autoimmune disorders go into remission. So it may be possible to withdraw the antithyroid drug in the third trimester. If the patient is severely toxic, then you need to keep the dose minimum, as I said, to keep the patient comfortable and the T4 at the upper limit of normal. If the thyrotropin receptor antibody is available, it's worth doing it in the first trimester, because once it's negative, then you don't need to worry about the fetus getting thyroid problems. At least the risk is low. But if it is positive, then you need to follow it up again in the third trimester and then in the fetus after delivery. So let's shift to the other side. Again, a young female, 7 weeks of amenorrhea, a TSH of 10.8. So I'm going to give you 2-3 scenarios. A TSH of 42, T4 of 4.2, and a T3 of 79, with or without a family history of thyroid disorder. When you have a TSH of 42, it really doesn't matter. And the third scenario, which probably is more common, what Dr. Bajaj was telling you about subclinical hypothyroidism. But in pregnancy, once the TSH has crossed 4, there is no question we have to treat this patient. So the point is the TSH may be borderline elevated, mildly elevated, or frankly elevated. You have to treat these patients with thyroxine. Time and again, even today, the gynecologist, the obstetrician refers the patient for termination of pregnancy. I want to stress on this not once but twice, that there is absolutely no place for terminating this pregnancy from the medical point of view. Occasionally, a worried couple, a couple who has been trained by their family doctor or their obstetrician, are so stressed out that they'd ask me, "Doctor, can you give guarantee that the child will be normal?" Now tell me, which doctor can give that guarantee? At least not I. When someone talks to me in that language, then I say, please go ahead and do what you want. It's your child. But as a doctor, my recommendation is don't terminate the pregnancy. We start with, these are the things which worry us in terms of overt hypothyroidism, in terms of premature birth, low birth weight, gestational hypertension in the mother, or occasional pregnancy loss, fetal neurocognitive development. But fortunately, with treatment, most of these things can be taken care of. In terms of treatment of hypothyroidism in pregnancy, there's not much to choose. It is the thyroxine which should be used. We should not use T3 in these patients of hypothyroidism. We start with the full dose of 1.7 microgram per kilogram of thyroxine, unlike what Dr. Ashu was talking or what Madam was saying, that you start with the smaller dose. Here we are in a hurry. We start with the full dose, early morning, empty stomach, nothing to eat after that for half an hour. In the non-pregnant state, we have been taught wait for 8 to 12 weeks to repeat the TSH and T4. But in pregnancy, we're in a hurry. So we start checking up every 4 weeks after starting treatment. Keep in mind that as the pregnancy advances, as the placenta increases in size, the baby's requirement increases, although the fetal thyroid starts working after 12 weeks. But it has been seen that 85% of women during pregnancy would require an increase in dose from say about 50% to about 80% in the thyroxine dose. So tell the patient right in the beginning that your dose will go on increasing every few weeks. Otherwise they get panicky, they get worried. Why are you increasing the dose every time? And generally this goes on to the 6th to the 7th month of pregnancy, and then it stabilizes. Sometimes you may have a lady, okay, so this is postpartum after delivery. If the lady was diagnosed hypothyroid subclinical during pregnancy, probably you'll be able to stop the dose medication. But if she was already on thyroxine and you have increased the dose of thyroxine, you can bring her back to the prepartum dose of thyroxine. Probably the last case that I'm discussing, she's married for 4 years, already on thyroxine 50 micrograms, and is just conceived. She's come to you with her thyroid function test for a second opinion. Clinically, she's euthyroid, no goiter. But if you look at her TSH, the first visit was 4.4, second time was 2.2, and now when she has come to you, it is 4.9. So there are two things that we need to stress. One, as I mentioned, 4.9, it's more than 4, needs treatment, is anti-TPO positive, needs treatment. So there is no question. And since she's already on treatment, you need to increase the dose between 25 to 30%. So whatever her prevailing dose, the simple way, instead of making it complicated of percentage and numbers, just tell them to increase 2 tablets a week. That is the easy way till the next investigation. Sometimes, you can't get your test, the patient is not near you, you give them advice, once you confirm pregnancy, till you come back to me, increase the dose by 2 tablets a week. So these are the summaries from the 2017 ADA guidelines, which have stressed on the TSH reference range. And now from India, we have at least 3 good studies which say that the TSH in normal first trimester is up to 4. So we don't need to rush into treatment. As I will show you in a summary slide later on, beyond 4, we have to treat. Below 2.5, we can wait and observe. Between 2.5 and 4 is where the confusion or the controversy comes in. And let's see what we can sort of summarize later on. So this is the slide I was talking about, between 2.5 and 10. See, because above 10 is overt hypothyroidism, there's no controversy. Below 2.5 is normal, you don't need a follow-up. So that's the situation. It's between 2.5 and 10, as I mentioned, there may be a controversy. Anti-TPO positive, you would treat them with thyroxine if it is above 4. But between 2.5 and 4, you could consider treatment. And I think given the treatment being safe, effective, not expensive, easy to monitor, I would suggest that we should look at treating these patients. However, if the anti-TPO is negative and the TSH is between 2.5 and 4 at the upper limit for Indian population, you can keep them under observation. But between 4 and 10, you would definitely consider treatment. So this sort of charts summarizes the approach to hypothyroidism when you don't have a clear-cut TSH of more than 10. Again, a common problem in our practice, our gynae colleagues keep referring patients with bad obstetric history and anti-TPO positive.
Hello.
Yeah. And we get a command that please treat the anti-TPO. Please understand, it is anti-TPO is a marker antibody and it's not the real antibody which is causing problems. So you don't need to treat anti-TPO. There are some studies which are, especially by Robert Negro, who says that a TSH above 2.5, you treat them with thyroxine even if they are euthyroid and the outcomes are better. Whereas this has not been duplicated in other studies. In addition, you have got recommendations for using selenium, steroids, aspirin, and whatnot. Multiple therapies tell you that we still don't know what to do. And the best thing is to keep this patient under observation and hope for the best. The infant of the thyroid mother should be checked for TSH between day 2 and day 5. We discourage the use of cord blood because cord blood, the TSH may jump up. And remember that the normal TSH in a newborn is less than 30, not the 2, 3, 4, 5 that we talk in adults. So don't label a newborn baby just because of a TSH of 10 or 15. It's less than 30. When you are in doubt, you can repeat it after 3 to 4 weeks. Thyrotropin receptor antibodies, if available in your city, are useful when you're looking at the possibility of a transient thyroid disorder versus a permanent one. However, if you're in doubt, treat them for the first year and then think what next. I'm going to conclude with this slide, which tells you the physiological changes during pregnancy. TSH may go down or there may be no change. A total T4 increases. I mentioned to you, it can go up to 50% towards mid-pregnancy. Free T4 is not supposed to change. However, let me add a little confusion. In the third trimester, the free T4 levels tend to be on the lower side. T3 is increased again because of TBG and thyroid binding prealbumin. Free T3 is not expected to change. Thyroglobulin is increased, but we don't really rely on it for any testing during pregnancy. And anti-TPO may or may not be there. So it has to be on a case-to-case basis that you want to do it or not. So I'm going to leave you with my email ID because I have, in this short period, tried to raise some points, give you some pointers. But if there are questions which we can't take up during the question answer session, I'll be happy to reply to your emails at a later date. Thank you very much for your patient hearing.
Thank you, Dr. Chadda, for giving such a nice and elaborative talk about the physiology of the thyroid hormone status in pregnancy and how we have to manage these females with the thyroid hormone disturbances, both in hypo and hyperthyroidism. We all are benefited by this. And now this is the time when we should go for certain questions. We have some questions in the chat box. And this is the question: what should be the TSH level to be according to pregnancy? I think this has been explained, Dr. Chadda, by yourself earlier also. Can you give?
Okay, so let me summarize again. You have a TSH above 10, absolutely no problems, you know what to do. If you have a TSH which is below 0.2, That is the time you have to think, is this physiological change? Is it a Graves' disease? Or like I said, more often it's a gestational thyrotoxicosis. The problem is between 2.5 and upper limit of normal, because earlier on 2.5 was taken as the upper limit of normal in pregnancy. But now there's data across the globe and especially from India, which has looked at in the normal first trimester as 4. Raman Marwar.
Us also does not look good in terms of, why are these guys taking money for, a birth control? So basically, I think we are not looking at generating money out of this thing even.
Hello.
Yeah, I don't know what was
Hello,
that.
please unmute all the.
So what,
audio visuals, please unmute yourself.
so between 2.5 and 5 is the controversy, treat or not to treat. Anti-TPO positive, please treat. Above 5, please treat. Anti-TPO positive or negative.
Another question is, can uncontrolled thyroid in pregnancy cause great growth failure? This is again for Dr. U. Chadda. Patient remains hypothyroid during pregnancy. Can it cause growth failure?
Generally not. Because like I said, after 12 weeks, the baby's fetus or the fetal thyroid starts working. Growth hormone, the pituitary axis is quite normal. The iodine content should be normal. All put together, you would not generally get any growth retardation in utero. But I hope such a situation doesn't come up. We diagnose, because now I think most obstetricians do look at the thyroid profile during pregnancy.
This is another question. A young female patient of 26 years old, otherwise lean thin, with TSH of 7.8. Should we wait or should we start treatment? I think this is the question appropriate for madam. I request madam to this.
So she's lean and thin. I've already clarified the lean and thin on the obesity is not going to make a difference as far as the TSH is concerned, but depends. The age, we don't know. And of course, if she's under 65, if she's having symptoms, if she has family history of thyroid disease, if she has a goiter, if her TPO antibodies are positive, then I would definitely go ahead and give her a trial. And then repeat after 3 months, subsequently after 6 months, annually, and monitor her accordingly.
Another query is, there is an elderly male of 74 years old with history of ischemic heart disease, hypertension, clinically euthyroid with TSH of 11.1. Should we start treating or should we wait? Can it exaggerate the ischemic heart disease? Again,
Yeah.
madam, I think you will be the right person.
I've already told you, see, above 65, we do not have any, with the data clearly tells us that the advantages, there are not many advantages of giving. In fact, it is more harmful. So the age here you said is 74 and there is already history of ischemic heart disease. TSH is 11. Again, we need to see how symptomatic the patient is, whether the patient's antibodies are positive, if there is a family history of thyroid disease. If the decision is made to start treatment, then I would just barely start off with a 12.5 microgram dose, and I would step up every 2 to 3 weeks. Not so we'd start very low and step up very slowly. And then, of course, take it from there. And I've said we have to look at the other associated parameters as well.
Thank you, madam, for your making this point clear. Another query is,
I wanted to add something.
yes.
This is a standard MD DM question.
Yes.
Patient with heart disease getting ready for CABG is diagnosed to be hypothyroidism.
Right.
Who do you treat first?
No, you would start. I mean, you would do the surgery. You would do the surgery.
We are not in a hurry to treat hypothyroidism.
No way. Start, the surgery comes first. Surgery comes first.
Even, madam, if the patient is overt hypothyroid?
Yes, even then I would go ahead.
So
Yeah, anesthetist can take care.
not any
Because
during recovery from anesthesia and
The interest, I mean, then it's very difficult to get this point to home. Just yesterday, this patient comes with a TSH of 30 on 50 microgram, and now he's taking 175 microgram, and the TSH is 60. 2 days later, 62. I mean, I'm just saying, and the patient has to go in for surgery. There's a fracture, road traffic accident, and the surgeon said, I will not operate. So I told him, unless you get me to talk to the surgeon, he will not operate no matter what you say, isn't it? So this is a big, we just have to convey this message that you can go ahead and operate. That fracture comes first rather than the thyroid, even in overt. And then you don't test after 2 days and 2 days and 2 days. You have to wait, you have to wait.
Yes. So after starting full replacement dose, we can go for the surgery of the fractures. But what about ischemic heart disease and CVD also?
Yes.
The anesthetic can take care of the recovery part. Don't worry.
Yeah. Another question is what features we should particularly see for a child to find out early evidence of hypothyroidism. Dr. Ashu, are you online? Because he was out of the town and while traveling he was doing it. So Ashu must have left because he has left for the Manali, and on our request he was continuing this with during traveling. So, madam, can you give this answer to this?
Absolutely. So we are talking of juvenile hypothyroidism.
Yes.
Okay. So growth retardation, number one, is the most important. So if they're presenting any child coming to you with short stature, right? All of a sudden there's some growth retardation need to be tested. It decreased in the scholastic performance. The mother says or the parents say that the child is doing well at school, but now all of a sudden the child has stopped. Then he's already shown you an example of precocious puberty. It can be both. It can be delayed puberty. It can be precocious puberty as well. Then, of course, the longer you delay, you saw those classical hypothyroid, the so-called myxedematous facies that you would get, typical features which on the spot, the child walks into the clinic and you say, oh, good God, what have you been doing for all these months? So this is the typical the thing. So scholastic performance, growth retardation, and of course the bone age would give it away immediately. Mentally, it's like cretinism, and there's a world of difference. They're not so badly off. Cretins are the most depressing of all.
Thank you, madam. Thanks a lot. Another question is, does uncontrolled thyroid in pregnancy cause growth failure or poor development of brain if T3, T4, TSH of the child at birth are normal? That is, his own thyroid is normal. So this kind of question, I think, Dr. Chadda, can you?
We've already answered this question.
Yes.
That as of now, and there's a large study which has come out, the patients who have been, the mothers who have been well treated for the hypothyroid state, at birth and even up to 8 years of follow-up, there is no neurocognitive deficit in these children.
And one more question is there, does we should go ask every pregnant female to go for the thyroid hormone testing? And if so, at what period of gestation?
So most of the international bodies, for various reasons, are not agreeing for universal thyroid screening. But I can tell you from the Indian obstetrics point of view, the way the whole FOXI arm and all the some societies that are there are screening for thyroid disorder on the first antenatal visit.
I would suggest universal, at least.
No. So that's what I'm saying.
Yeah, I know. I think universal is a good idea. And I think as soon as the patient comes in, the first test should be done. And then, of course, you have that long list which I gave you of risk factors. There's a long list of risk factors which need to be addressed, like if you have goiter, antibodies, anemia, family history, surgery, radiation. So there's a long list which needs to be looked into. But universal, I think blanket, I would go in for that.
Yes. Thank you, madam. Thanks a lot.
Thank you.
Thanks a lot. Both of you have given very good answers to all of our...
The questions were good. I'm not sure about the answer.
And
the answers were complete.
All the three speakers have done a very good job and delivered very good lectures with a very clear-cut message to the audience. And we all are obliged by both of you and all three of you. And we also expect similar kind of cooperation for educating and doing CMEs in Rajasthan Endocrine Affiliate. Thank you very much, madam. Thanks a
Great
lot.
talk, Manoj. Thank you. Lovely seeing you. And Prakash and Sanjay and Prem and everybody here.
Yeah, you
I
please.
saw a glimpse of Sanjay, but he's sort of, I think he's
No, madam, he is very much
he'll be
online.
here. I know he'll be. Namaste, Sanjay.
Namaste, ma'am.
Thank you, Prakash. Thank you,
Thank you, madam. Thank you, Dr. Chandra.
I'll be around. Sanjay is a must listen to for any talk.
Yes. So now, mic over to the Dr. Sanjay Saran.
Yes, sir.
Thanks, madam, and start the next session. Dr. Kala, good evening.
Good evening, sir. Namaskar.
Dr. Sanjay, will you be speaking or?
Sir, we should start for next of our topic, na?
Yes, right.
Yes.
Dr. Banaram, introduction of Dr. Sanjay Kala is very brilliant to speak. Dr. Sanjay Saran, will you be introducing him?
Yes, sir. Sure, sir. Yeah, as we know, Dr. Sanjay Kalra, everybody knows him very well as far as the Endocrine Society is concerned in India or abroad. Na? He is visiting professor of AIIMS Rishikesh, India, immediate past president of Endocrine Society of India, and he was vice president, and he is now vice president of South Asian Federation of Endocrine Societies, and his education editor, International Society of Endocrinology. He has a lot of publications in national, international journals, and he's also known for his good behavior, and also a very enthusiastic president in Endocrine Society of India till now, actually, if we have seen. So now I'm inviting Dr. Sanjay Kalra to come in.
I would like to speak one sentence. Because of him only, the Journal of Endocrine Society of India started running, and we are at very good position. And we were looking for the journal for last since 1994 when we were doing DM. And it was the efforts of Dr. Sanjay Kalla that our journal could become regular and has attained a very good, very high rank. Thank you.
Thank you, Dr. Prakash sir, and thank you, Dr. Sanjay, for that very warm and very affectionate welcome. When I speak at Rajasthan meetings, I feel very much at home. मुझे actually लगता है कि राजस्थान मेरा अपना state है. There are many reasons for that. We have a lot of friends, seniors like Dr. Prakash Keshwani sir, juniors like Dr. Sanjay, colleagues. So we're all one family. Another reason why I feel very much at home is because हमारी languages बहुत मिलती हैं, हरियाणवी और राजस्थानी. तो बड़ी handy languages हैं हमारी, and सिर्फ हम ही समझ पाते हैं कि handy का मतलब क्या है, and that makes us unique. It makes us special. Another reason why I like being part of Rajasthan meetings is because I love Rajasthani literature. So when we look at this story, Rajasthani folklore of Dhola Maru, the Prince Dhola and his beloved Maru. It's a very heart-wrenching story, but it's a happy ending wali story. The happy ending is that out of death, the love of Dhola and Maru could bring them back to life. Even though a serpent bit Maru, and even though Dhola went into grief, still God was so impressed with their hard work and with their sincerity that he brought them back to life, and then they lived happily ever after. The same thing is occurring in our diabetes care today. We have been working hard for the past many years, many decades now, and finally all the hard work, all the sincerity seems to be getting rewarded. How is that possible? That is possible because we've now begun understanding what the human body is, how all metabolism is interlinked. So earlier when we were managing diabetes, we would focus only on glucose-centric approach, or just upon trying to bring the glucose parameters, the glycemic parameters to normal. We then understood that comprehensive management is required. We have to not only focus on glucose. Glucose control is not an end in itself. It is actually a means to an end. And that end that we want, the end that we actually want is longevity, healthy longevity. And how can we achieve healthy longevity? By ensuring good heart and kidney health. So therefore, we understood that cardiac and renal and glycemic management all should occur together. Until 10 years ago, however, it was not possible to do that. We had different drugs for different things. So you would end up giving something else for glucose. The glucose lowering drug might reduce the glucose levels, but it might precipitate kidney and heart disease. In the past few years now, we have been able to find drugs that can be used for all these things together, for the entire metabolic spectrum. The same drug helps in achieving glucose control. That very same drug helps in improving kidney health and heart health. And it is this achievement which is actually going to give us a healthy and happy ending, like the Dhola Maru story. We also term this concept endocrine exaptation. Endocrine exaptation means that a drug which was originally used for endocrine function, like dapagliflozin, is now being exapted or adapted for use in non-endocrine indications as well. Initially, we thought that dapagliflozin has only one mechanism of action. It inhibits SGLT2 receptors. It is insulin independent. And by inhibiting SGLT2 receptors, it removes excess glucose from the urine. So therefore, it acts as a glucuretic or glucoretic drug. It also acts as a glucose restriction mimetic. Because it takes out glucose from the body, it mimics glucose restriction. Maybe a better term for this would be carbohydrate restriction mimetic, and even better would be calorie restriction mimetic. Why we call it a calorie restriction mimetic? Because roughly 280 calories extra are lost per day when dapagliflozin is prescribed. Because of this mechanism and because of other mechanisms, which we'll discuss later, DAPA is actually able to, like other SGLT2 inhibitors, DAPA is able to provide comprehensive metabolic control. So not only does it help in reducing hyperglycemia while avoiding hypoglycemia because it is insulin independent, it also helps in optimizing weight, optimizing vascular function and vascular tone. It helps in reducing blood pressure, both systolic and diastolic. It improves cardiovascular health and renal health. So if there is one drug, one oral drug that can claim to be a management for all aspects of metabolic syndrome, that might be SGLT2 inhibitors like DAPA. This is also reflected in this slide, where you see that you have glycemic as well as extra glycemic effects of these drugs. So HbA1c control, glucotoxicity reduction, body weight reduction, and also various extra glycemic effects occurring at the level of the heart, the vascular tree, and the glomerulus. All these finally lead to cardiorenal protection. Not only cardiorenal safety, but also cardiorenal protection. Let me spend a minute here on this. As an endocrinologist, I could be excused in the past for thinking that everything about cardiology is coronary arteries. But there is much more to the heart than coronary arteries. The myocardium, the pericardium, the endothelium, the valves, all these are there. So if you have a drug which is able to act upon the myocardial the arteries, that is the coronaries, and also upon the myocardial cells, by improving the bioenergetics of the myocardial cells, that will give overall comprehensive cardiac care. Similarly, in the kidney, we have much more than the glomerulus. The tubules are there, the glomerulus, the interstitium is also there. And if you have a drug which acts not only upon the tubules, but also upon the glomerulus and upon the interstitium, in the interstitium, it is able to modify oxidative stress, able to modify TGF, and able to increase erythropoietin production. All this will give comprehensive kidney protection. So then, irrespective of what we call the cardiophenotype or the renophenotype, we will be able to get good health. When we look at blood pressure lowering drugs, when we were students, Dr. Prakash and Dr. Sarta madam will agree The classification we were taught was blood pressure lowering drugs which act on preload, like for example, furosemide, and those which act on afterload, for example, nifedipine. Later on, drugs came into use like ACE inhibitor and ARB, which acted on both pre and afterload. SGLT2 inhibitors are able to act on all three aspects of the vascular tree. They act upon the preload by reducing, by causing osmotic diuresis and by reducing the total volume. They act upon afterload by reducing endothelial stress and by causing vasodilatation. And they also act upon the load producing engine, that is the myocardium itself, by reducing left ventricular wall stress and by improving myocardial energetics. So therefore, SGLT2 inhibitors are a unique class of drugs which act upon both preload and afterload and the load producer, that is the myocardium. They are also unique because they act upon the entire spectrum of cardiac function and also renal function. Now, let us see if we have proof for this. In Dhola Maru, the proof of the story is that finally Dhola and Maru remained alive and then they lived happily ever after. This living happily ever after with SGLT2 inhibitors, is this true? And how soon does it occur? Dhola Marus were a very long story. Lots of grief, lots of unwanted events, villains also playing their role and preventing the two beloved ones from coming to each other. It took a long time for their story to have a happy end. But with SGLT2 inhibitors, the opposite is true. When you look at the Kaplan-Meier curves for empagliflozin, you find that within 3 months, there is a statistically significant divergence of the two curves. So not only is the impact of empagliflozin on CV outcomes significant, it is also swift and it is sustained. So you have a swift, sustained, significant improvement in CV outcomes when EMPA is used. We talk to our patients about this as well. And we talk to them, do you get your insurance done? So they say yes. जो classical तरीका है लोगों का सोचने का इंश्योरेंस का, वो ये है कि हम पे आउट करते रहेंगे. You will keep on paying out. You keep on paying out for 5 years, 10 years, 20 years, or maybe as long as you're alive. And after that, you get payback. But now there are insurance schemes where you begin getting payback within 3 months or 1 year. So this is the kind of payback. आप दवाई पे पैसे खर्च रहे हो, you are spending a few rupees, and the cost of the rupees has also gone down markedly. You are spending money, but you are getting the insurance and you are also getting a payback or improvement, good outcomes immediately in a very swift manner. The same picture we see with canagliflozin. Reduction in 3-point MACI, reduction in hospitalization for heart failure, all occurring in a very swift manner, in a sustained manner. With dapagliflozin also, we see that when the composite of hospitalization for heart failure and cardiovascular death is taken, you find that there is a statistically significant reduction in this outcome. The hazard ratio is 0.83. This is statistically significant. When you look at the 3-point MACI, the drug is good, but it loses out for superiority. It is non-inferior. Still, let us focus on DAPA alone. If we look at renal endpoints, we see a very statistically significant reduction of 24% in composite renal endpoints. Irrespective of what kind of outcomes you take, you will find that DAPA 10 mg is actually able to improve renal outcomes. So overall CV outcomes are improved. So far, we have spoken on the use of SGLT2 inhibitors and dapagliflozin in diabetes. And we have seen that they help improve CV outcomes. But we use the term endocrine exaptation. Exaptation means using a drug in non-endocrine indications. So let us see what this drug has to offer us in heart failure. And this is something new which has come into, the evidence has been reported just a year ago, less than a year ago. Here what we see is that in DAPA heart failure, in patients who are at risk of heart failure, the risk of CV death, the the risk of hospitalization for heart failure or even a visit to emergency room is reduced markedly. 26% reduction in this composite endpoint in DAPA patients, 17% reduction in all-cause death, and this benefit is valid for people with diabetes, for people without diabetes, for people with dysglycemia, which can be diabetes or impaired glucose tolerance, and those with normoglycemia. So irrespective of the glycemic burden or the glycemic load, we find that dapagliflozin is able to improve the health of patients with heart failure, which means that it should be used as a primary therapy in patients with heart failure with restricted ejection fraction. The same benefit with type 2 diabetes and without type 2 diabetes. Almost similar benefit is seen in patients with whatever HbA1c tertile they are in, those who are pre-diabetic. And the reason for this is that dapagliflozin actually acts upon the myocardium to improve the bioenergetics. The term we use for this is Robin Hood effect. Robin Hood was a person who stole from the rich and gave to the poor. We might also call it the Rajasthan effect or the Rajput effect, because in Indian history, Rajasthan was one state, a border state, which stood up to invaders from the west. So Robin Hood, what he did was he would steal from the rich, give to the poor. He would create a balance or equipoise in society. In a person with diabetes, there is hyperglycemia. But that glucose, which is actually an energy substrate, is of no value. It is just like a hyperglycemic person's heart is just like a person stranded in the middle of the Indian Ocean without a drop of water to drink. So this hyperglycemic person has got a lot of glucose, but because of lack of insulin, the glucose-based metabolism is not able to utilize glucose. So the myocardium gets less energy. It's not able to function properly. It's not able to pump properly. If we redistribute the metabolism, Robin Hood style, we take from glucose metabolism and we give to fatty acid-based metabolism or ketone-based metabolism. Then these myocardial cells can use fatty acids as a substrate for energy. Just like you take saline water and you convert it into clean water without salt. It becomes drinking water. So what dapagliflozin does is it shifts from glucose-based to ketone-based metabolism slightly, not so much so as to cause diabetic ketoacidosis, but just enough to cause a subclinical ketosis, which helps improve the function of the myocardium. Many of us would say, but ketones to kharab hote hain, ketones are bad for health. And that is true as well. So the point here is subclinical. If you do too much of this and the patient goes into diabetic ketoacidosis, then that is bad for health. Similarly, like let us say you in India, we have black economy and white economy. Now, both have their own role to play. If you absolutely abolish the black economy or the unorganized sector, then also people go hungry. But at the same time, if everybody stops paying their taxes, if there is no white economy left anymore, everybody stops paying their taxes and people shift all their money to Dubai or to Switzerland, then also our country will collapse. So you need a balance of both. Similarly, with DAPA, SGLT2 inhibitors, you need a balance in the myocardium. To create this balance, all we need to know is the contraindications for DAPA. And you need to know the causes of DKA. All said and done, there are three causes of diabetic ketoacidosis or euglycemic ketoacidosis. One is deficiency of insulin. The second, deficiency of carbohydrates. Third, deficiency of fluid. So make sure that a patient whom you have prescribed SGLT2 inhibitor, especially if he is non-diabetic, has sufficient insulin, whether exogenous or endogenous, takes sufficient carbohydrate. The patient on DAPA should not suddenly decide to go on a keto diet. And the patient should not be dehydrated. Patient should take enough fluids. If these three things are maintained, sufficient insulin, whether exo or endogenous, sufficient carbohydrate intake, and sufficient fluid intake, there is no chance of complications. In fact, the opposite is true, because when we look at these patients who were admitted in the DAPA heart failure study, what we actually found out is that the rate of progress of non-diabetics to diabetes came down. So DAPA was actually used not only for management of diabetes, it was also used for prevention of diabetes. And this impact on prevention of diabetes is sustained for up to 2 years. So you actually find a statistically significant reduction in the risk of diabetes when dapagliflozin is given. Let's look at this slide here and see whether this slide is more relevant to India or less relevant to India. When we look at diabetes prevention studies, the original DPP was done in Finland. The annual rate of progression from pre-diabetes to diabetes is 6%. Another DPP done in China showed that the annual rate of progress from pre to diabetes is 12%. And when DPP India was done, that showed an annual progression of 18%. The data that we have in front of us seems to mirror the Finnish data. At 12 months, if you see carefully in front of you, around 5% of the patients, of the participants, had converted to diabetes in the placebo group. In DAPA, the rate was statistically significantly lower. Imagine the benefit that would accrue to our population, which otherwise in the placebo phase is going to go up to 18%, and how much reduction we can bring with DAPA in India. So therefore, what this slide is telling us is endocrine exaptation. You can use DAPA in heart failure, even without diabetes. Secondly, preventive pharmacotherapy. You can use the drug to prevent diabetes in our country, men and women. And these examples that we are using, for example, the Robin Hood effect or the insurance with immediate payback effect. These are nice ways of explaining to our patients in Hindi or in local language why they should add this drug to their existing therapy. And the hazard ratio, 32% risk reduction, is statistically significant, also clinically significant, and also significant from a public health point of view. Let's move on now to our impact on the kidney. So we have spoken of SGLT2 inhibitors being useful in diabetes, being useful in improving CV outcomes in diabetes, reducing heart failure and CV death hospitalization in non-diabetics, preventing the progress of non-diabetes to pre-diabetes or pre-diabetes to diabetes. In the kidney as well, SGLT2 inhibitors have equally, if not more, beneficial effects. So canagliflozin, empagliflozin, and dapagliflozin all are able to improve kidney outcomes. But then the hypothesis was, will the same impact be true in people without diabetes? So DAPA CKD study was used for this. And here the EGFR inclusion criteria has been taken down to 20 ml per minute. So even at 20 ml per minute GFR, this drug has been used. There may be no glucometabolic benefit at 20 or 25 or 30 ml per minute, but still there is a vasculometabolic or a renometabolic benefit. This is again statistically significant, and this is evident from the slide in front of us, a 39% risk reduction in kidney outcomes or CV death when dapagliflozin is given to diabetic as well as non-diabetic individuals. A 44% reduction in CV outcomes and in renal outcomes and renal death when DAPA is given, irrespective of whether the patient has diabetes or not. 46% is huge. This kind of improvement you cannot get. Patients may say that, but is this meaningful? How do I know that what you're telling me is correct? Then you use this outcome, which is all-cause mortality. If we prescribe dapagliflozin to a person who is at risk of kidney disease or who is in the early stages of kidney disease, there is a 31% reduction in all-cause mortality. So therefore, this drug can be used in people with and without diabetes both, irrespective of the renal phenotype, irrespective of the EGFR, as long as it is 20 or more than 20, irrespective of albuminuria or microalbuminuria, macroalbuminuria, or normoalbuminuria. So recently we have begun to understand what non-albuminuric DKD is. Irrespective of what kind of DKD the patient has, the drug is safe, it is effective, and it will actually improve outcomes. Overall, this drug is safe to use. You remember we talked about the 3 things we should be careful about: sufficient insulin, sufficient food, sufficient water. If this is taken care of, then dapagliflozin is actually able to achieve good cardiorenal benefit, safety, and better outcomes in a wide spectrum of patient population. Those with established ASCVD, those with risk factors for ASCVD, those with restricted ejection fraction heart failure, as long as the EGFR is more than 30. And in DAPA-CKD, I apologize for saying 20. The EGFR actually was more than 25 in this study. However, there are other studies going on where the EGFR level has been taken down to 20. We began by speaking about Dhola Maru. Let me share another tale from Rajasthan, and this is the wishing tree. You are all aware of this. So basically, this traveler who was very tired, he came and sat below the kalp vriksh. Whatever he thought of, he got the same thing. When he thought of food, he got food. When he thought of a bed, he got a bed. But when he thought of demons, he found a demon or a rakshas in front of him. Let us think happy, think healthy. Let us speak healthy with our patients. And the kalp vriksh that we are sitting under is in our clinic only. It is not anywhere else. You do not have to go to the Thar desert to find that kalp vriksh. If you think healthy and think happy in your clinic, if you speak healthy and speak happy in your clinic with your patients, you will actually achieve health and happiness, not only in your patients, but also in the community that you serve and also within yourself. So let us begin speaking and thinking in a healthy way, in a more proactive way with our patients. Let us begin talking to them about the benefits of SGLT2 inhibition for the management of diabetes, for the prevention of diabetes, and also for better outcomes in heart failure and in kidney disease. Once we begin thinking and speaking in this manner, we will find that the community will respond, just like the kalp vriksh responded, and we will be able to actually improve the health of all our countrymen and women. With this, thank you. And like I said, it's always a pleasure to be part of a Rajasthani meeting. Thank you very much.
Thank you. Thank you, Dr. Sanjay Kalra. One, for remembering the history of the Rajasthan, Dhola Maru and kalp vriksh. And second, you have given a wonderful speech clearing the doubts about how SGLT2 works, what benefits we can have. And at the around 5 years back, when this group of the drug came, even majority of the physicians were worried that how this can be not detrimental to the kidneys because they are exposed to them a good amount of glucose in the glomerulus as well as in the tubules for a long time. And now the things are totally opposite to that. How could it happen? Can you give some more detail?
Sir, I think this was new learning for all of us. Even I remember 10, 15 years ago thinking that ketosis is bad. Yes. And then initially when the data came regarding canagliflozin, there was a lot of data on euglycemic ketoacidosis. I think that is because the doctors did not understand in which patients to use and whom not to use. If we understand the contraindications and the caveats, then things become easier. So gradually as our understanding has evolved, our usage, our pragmatic usage has evolved. In patients who are very sick, very frail, you can remember the dangerous Ds. D for duration of life, very elderly, very young. D for deranged renal function. D for dehydration. D for perhaps digit ischemia. D for drugs which are nephrotoxic, like D for high dose diuretics and D for NSAIDs. In these indications, in these situations, we will try to avoid using the drug. Otherwise, feel free to use it and just be careful. The physician should be able to keep a close watch for acute kidney injury. Any red flags that you see for acute kidney injury, which can be pre-renal, renal or post-renal, be careful, be vigilant. As long as that is not there, you have a patient with stable CKD or with stable coronary artery disease, chronic stable angina, continue using the drugs and you will find the benefit.
So this drug has been recommended for that, even for the non-diabetic, for heart problems. But when that initially the drug came, the added advantage was loss of weight in addition to controlling diabetes. Do you think that those patients who are non-obese should also be given this drug, because the added advantage of weight loss is not there? But should we give this drug to those patients also, non-obese?
Yes, sir. There are many things to look at regarding this, but the point that Dr. Keswani sir has raised is very important. So let us try to dissect this. If anybody in medicine says कि सभी को दवाई दे दो या सभी को दवाई मत दो, that we should view with a pinch of salt. We have to see the ifs and buts, the caveats. Even water, somebody like our friends in alternative medicine, they say जी हमारी दवाई का कोई side effect नहीं होता. So I find it very funny. अगर आप अंधे हो, आपको side effect दिखेगा ही नहीं, आपको पता ही नहीं चलेगा. So if you cannot measure the urea creatinine, how will you get to know?
Right.
So similarly, in let us say we have an individual, why should I give DAPA? If the patient is normal, no point in giving. If the patient is at high risk of heart failure or the patient is at high risk of worsening of CKD, then I will consider giving. Now, if the patient has frequent episodes of acute kidney injury or has many red flags of acute kidney injury, I would be safer not giving. Now, after having decided this, then we come to the weight. If the patient is normal weight and normal weight composition, like subcutaneous tissue versus visceral tissue, central obesity versus peripheral obesity, if it is all normal, already the patient has barometabolic optimization, then again maybe the drug will not act so much. But in India, we have what we call the thin fat phenotype. Our BMI is normal, but our tummies are fat. The waist circumference is more. There is also a term known as normal weight obesity. Normal weight obesity का मतलब क्या है? The weight is normal, BMI is normal. But when you do a DEXA for body composition, you find that the fat percentage is very high. We continue using body weight and BMI to measure obesity. But we must realize that these are 200-year-old parameters. Because DEXA is very expensive, it is not available. That is why we are not using it. Otherwise, ideally, adiposity should be measured that way. So if you have a normal weight person who is adipose, centrally adipose, or who is at high risk of heart failure or CKD, then the drug will be beneficial.
Thank you, Dr. Kala, for clearing this point also. As time is not permitting, there are so many queries, and we all appreciate your presentation and the enlightening us regarding the SGLT2 inhibitors. And we also request your contribution to your cooperation in the next CMEs also to deliver talk to our Rajasthan physicians and endocrinologists. Thank you, Dr. Sanjay Kalla. Dr. Sanjay, will you like to speak something? Sanjay
Yes, sir. Dr. Kalra is a very nice person, just like you, sir. He's very good helping attitude, and he's promoting young endocrinologists or young doctors, sir.
Yes.
So we don't have much words to say about him, na. We don't have even words, na.
Yes. Thank you, Dr. Sanjay.
Thank you, sir.
Thank you, Dr. Sanjay Kalla. Thank you, everybody. Thank you, Dr. Chadda, madam. Thank you to all the speakers for enlightening us, for giving good talks, making us wiser. And in future also, we will try to get associated with you. Thanks a lot to Dr. Sanjay Kalla. Thank you.